and welcome to our module on Labor Management 1. When the patient has reached their third trimester, it's important to start counseling the patient on the labor process. It's important to understand what their goals of their labor may be, because we want to make sure that we're trying to accommodate every possible need and want of the patient, while we're also trying to provide the most safe birth experience for the patient and the baby. It's important to be the patient's advocate and to make them understand that we're a team and we're going to try to work together to create a very safe and effective birthing atmosphere while making sure that everyone is as healthy and happy as possible. If a patient wants to create a birth plan, this is a good opportunity for them to understand the questions that they should be asking and to clarify their intentions before we go into the labor process, as this can add stress to every situation. This also gives us an opportunity to discuss why we recommend certain things throughout the labor process, so the patient can understand that these things are not meant to be hurtful or invasive, but they may be medically necessary for safety precautions as well as in emergency situations. During the third trimester counseling, we also should be talking to patients about kick counts. Kick counts are a way for us to understand if the baby is being active. When the baby is active, usually this denotes that the baby is healthy. When instructing a patient to do kick counts, we should tell a patient to go to a quiet room and to lay on their side. They may bring a glass of juice or cold water with them because oftentimes this can wake the baby up. They should then count every single movement that a baby makes within a 1 hour period of time. The baby should make at least 5 movements, both big or small, within the hour. If the baby does not move at least 5 times within an hour, then we go on to the second hour and the baby should move at least 10 times. If the baby does not move at least 10 times within those 2 hours, then we'll be instructing the patient to go to labor and delivery to get a non-stress test to assess for fetal well-being. Whenever the patient gets to that first level, whether it be 5 movements or 10 movements, they may be done. So if the patient feels 5 movements within 5 minutes, then the patient no longer needs to continue. Again, if the patient does not feel those 10 movements within 2 hours, then the patient should be evaluated at labor and delivery or in your office setting if you have an NST available. We also should discuss other precautions, such as precautions for rupture of membranes, as well as vaginal bleeding, and also to discuss contractions. If the patient has leaking of any kind in the third trimester, it's most valuable for them to come get evaluated within the office or at labor and delivery because the risk of infection with prolonged rupture of membranes is very high. Occasionally spotting or potentially even very light bleeding can be normal in the third trimester because of cervical change. But if the patient is filling 1 full pad in an hour, then the patient should be evaluated again in the office or on labor and delivery. This can denote a placental abruption, and this can turn into a surgical emergency. If the patient is having painful contractions at least every 5 minutes or less, lasting at least 2 hours, then it may be advisable for the patient to go get evaluated at labor and delivery for labor. It's important to make the patient understand that they should be breathing through these contractions for them to be strong enough to produce labor. If they're just mild contractions, these may be Braxton Hicks, and that can be quite normal in the third trimester. Again, it's important to talk about what type of environment the patient intends for their labor experience. You want to understand if the patient intends on bringing people to support them, such as their spouse, their relatives, or their doula. Does the patient intend to have a photographer? If they do, it's important to understand their goals of their photographer and to describe to them any policies that the hospital may have against photographing or recording the delivery. Sometimes this requires them to sign a consent form in order to allow those people into their room. Does the patient want special music, or do they want dim lighting? Do they prefer to have quiet in their room? Or are they planning on having regular conversation? It may be advisable to discuss outfits to the patient because we do provide hospital gowns to them, but oftentimes they'll feel more comfortable in their own home clothing. If a patient has never birthed a child before, it may be advisable to discuss with them the cleanliness of their clothing because oftentimes these clothes will be ruined in the labor process. It's important to outline safety when it comes to nutrition and hydration in labor. There are certain hospital policies at most institutions that prevent them from eating during certain stages of their labor. This usually surrounds the use of epidurals. If the patient has an epidural, oftentimes anesthesia does not want them to eat after this point, but they can have things such as clear liquids or ice chips, just depending on the institutional regulations. Most institutions involve student teaching, so it's important to understand the patient's need or desire for staff involvement. If they don't want students or residents to be involved in their birth, it's important to understand that prior to active labor so that we can ask students and residents to avoid those rooms. It's also important to discuss with the patient the staff that may be involved in their labor and understand their roles so that they're not nervous or discouraged when these people arrive. The patient may ask you to limit vaginal exams, and you may discuss with them the goals of having exams at certain periods of time. Most of the time, it's not important to examine the patient regularly, but you may want to discuss with them that it's needed at certain points, such as fetal distress, or potentially if they're not progressing in labor. If a patient wants to stand or walk or potentially use the birthing ball, you must discuss with them pain management because it's not usually possible for them to do those things with an epidural. Does the patient want to use the shower or the bath? Again, this is similar for this situation. Oftentimes, patients will ask not to have an IV. This sometimes is a non-negotiable because if the patient is to have a hemorrhage or potentially the need for an urgent cesarean section, we must have IV access for these things. Most of the time, with reasonable explanation, some patients don't desire fetal monitoring within labor. Some institutions allow for fetal monitoring to be intermittent or every hour for several minutes if they're in latent labor. But most institutions require patients to be on the monitor continuously if they're in active labor. Some patients don't desire an amniotomy or having their water broken in labor, and so it's important to discuss with the patient times that it may be appropriate to do this for safety. This would be in times of fetal distress or possibly large gushes of vaginal bleeding. If a patient doesn't desire to have augmentation, it may be important to discuss certain times that we might recommend augmentation, such as with prolonged rupture of membranes or fetal distress. Also, things such as high blood pressure might make us want to expedite delivery, and augmentation may be required at this point as well to avoid things such as cesarean section. If the patient does not desire pain management, it may be advisable to talk to the patient about the right to change their mind. This may be especially true in patients that have never had children before because they don't know what to expect. It's important to understand the patient's desire for birth positioning because if they want odd or different positions that you're not familiar with, then you may want to brush up on those things so that you understand how to safely or effectively deliver the baby and to examine your comfort level with these positions prior to going into labor. Does the patient want coaching during her pushing stages? If she doesn't want you to count or to coach her through it, she may be more effective without these interventions or with silence. The patient oftentimes has the choice to have a mirror to watch the delivery of the baby or to touch the top of the baby's head when it's crowning. Some patients have a strong desire to do these, but most patients don't want anything to do with them, so it's important to understand this prior to their delivery. The patient may also have a desire for an episiotomy versus natural tearing. Most of the time we allow the patient to tear on their own, but in certain situations it can be safer to go ahead and do an episiotomy. And it's important to discuss these situations with patients before you go into this labor. The postpartum period is also important to discuss with the patient. Does the patient want the baby on their chest and skin to skin right after delivery, or would they like the baby to be washed off? Do they desire delayed cord clamping? This situation is generally standard of care at this point, but most of the time we allow the baby to receive all of its blood until the cord stops pulsing, and then we will clamp and cut the cord after. We also want to understand who's going to be responsible for cutting the cord so we can get the scissors to the right person. Infrequently, patients want to bank the cord blood for certain use later, but patients have to get cord blood banking kits prior to delivery, so this is a good discussion point in the third trimester so that they can obtain these things and bring them to the hospital. It's important to note the patient desires to keep the placenta because otherwise we will keep it out of formalin and keep it in a special place for them to take home with them. It's standard of care to give the patient Pitocin postpartum to lower their risk of postpartum hemorrhage, but very infrequently patients want to decline this. It's important to discuss safety concerns, especially if the patient has a greater risk of hemorrhage, and to have a reasonable discussion about why we advise this. If a patient has an extensive repair, it's important to understand if the patient wants anesthesia for this, and if they don't desire an epidural, it may be important for them to understand if they get an extensive repair, an epidural may be helpful at this point. If a patient's having a planned cesarean section, it is still important for them to make a birth plan. We want to understand if they are intending to have a spinal versus an epidural or potentially general anesthesia. Usually patients get spinal anesthesia for a planned cesarean section, but it's important for them to understand the reasons why they may need an epidural versus general. Generally, general anesthesia is only given to patients that are candidates for spinals or epidurals or in emergency situations. Generally, a patient is allowed one support person within the cesarean section suite, and it's important to understand who that person might be. In certain situations, we may be able to offer the patient music or dimmed lights within the cesarean section. This is often called a gentle C-section because it's less traumatic for the patient. If the patient desires to have their hands free because it makes them nervous to be strapped down, we just need to denote reasonable expectations. The patient still must be relatively motionless because we are operating within a surgical field. And if the patient were to accidentally bump the surgeon or potentially the assistant during a critical point in the cesarean section, it may put the patient at risk. Oftentimes, we do have a clear surgical drape that can be dropped while the baby is being delivered. If the patient desires to see the baby delivered, we can do this, but they must understand that they may see blood and potentially the incision while this happens. Sometimes the patient requests low voices or quiet during the C-section, and it's important to respect this as much as possible to make the patient less nervous. It's also important to understand if the patient wants us to explain the procedure to them, or would they rather just have quiet and music and talk to their partner during the procedure. Most of the time we try to get the baby to the mother as soon as possible, but occasionally the patient is very nervous about having the baby next to them in the operating room because they're afraid of dropping them. It's also important to know if the partner is planning on going to the baby warmer to be with the baby, or does the patient want the partner to stay next to their side during the operation. Occasionally we can offer the patient skin to skin in the operating room or potentially even breastfeeding, but it's nice to know this up front so that we can prepare for it ahead of time. It's also imperative to know the birth plan for the baby. Are we planning on delaying the baby's bath? Sometimes this can be beneficial for the baby's health. Do the patients intend to vaccinate their child? Do they want erythromycin ointment in the baby's eyes? Or do they want to give the vitamin K shot? These things are not necessary within the first few hours of the delivery or a cesarean section, but it is important to do these prior to the baby's discharge and especially within the first 24 hours if possible. It is recommended to get a heel stick for the PKU test, but oftentimes the patients will decline this. Do they want suctioning for their baby? This can be traumatic for the baby, but it does remove secretions that make it difficult for the baby to breathe or feed. Is the patient intending to breastfeed? We can give certain support for that within the hospital if we establish this ahead of time. Does the patient only intend to formula feed? This is also important because we don't want to berate the patient with a bunch of breastfeeding advice if they don't intend to breastfeed. Does the patient want to give the baby a pacifier, or do they want to avoid this? Again, clear communication up front can make us understand the desires of the patient. And does the patient want to delay weights and measurements for their baby because they want to continue skin to skin as long as possible? If the baby were to undergo any medical examinations or their hearing screen, do the parents want to be present for that, or would they rather have these done outside of the room? Noting all of these things up front can be very helpful so that we don't cause confusion or stressful situations during delivery or the postpartum period. If a patient's having regular, strong contractions for a certain period of time, we may request them to go to labor and delivery or to the office for a labor check. Generally, we follow the 5-1-1 rule. The contractions must be 5 minutes apart or less, lasting at least 1 minute, and those contractions last a total of at least 1 hour. If this happens, sometimes we instruct them to go to labor and delivery, but very rarely to the office for a labor check. We would then do a cervical examination on admission to labor and delivery or at the office, and then we would generally recommend a cervical examination by usually the same person 1 to 2 hours later. If there's significant change, then we would oftentimes admit them to labor and delivery. Significant change oftentimes is subjective, and it's important to give the patients reasonable expectations that it might be slightly off. Significant change depends on gestational age, gravity and parity, as well as their NST status. If the patient is less than 39 weeks 0 days gestation, we cannot augment labor until they're actually in labor. If they have had children before, oftentimes labor kicks in much quicker and they have less time to get back to the hospital if they're discharged. So we may observe them longer, or we may have a lower threshold for admission for labor. If the patient's NST or non-stress test is category 1, then oftentimes we have more leeway for discharge. But if a patient's NST has any decelerations or minimal to absent variability, then obviously we would keep them for observation longer or potentially expedite their delivery by an induction. If a patient complains of leaking of fluid, we would want them to have a rupture of membranes check or a ROM check. If they have a large gush or continuous leaking of fluid, it's advisable for them to come in because we don't want to put them at risk of infection. Sometimes, if we're unsure, we'll have them place a pad on and observe for 1 hour. If this pad is soaked, then obviously they would come to labor and delivery for an examination. Sometimes we can do this in the office, but oftentimes we don't have tests such as amnisure, which is the most accurate testing. Usually the nursing staff will check ferning, pooling, and nitrazine with a patient with prominent leaking of fluid. Sometimes we can do those tests called amnisure and ROM Plus that look for the PAMG1 protein that is found within the amniotic fluid. Very rarely we can do an amniotic fluid index, but this is more often done as a bedside ultrasound that is not formal or done by the ultrasound department. If a patient describes decreased fetal movement, then we oftentimes will tell them to do kick counts to see if the baby is active and healthy. We usually advise patients to lay in a quiet place on their left side. We have them drink juice or very cold ice water to wake the baby up. We then count the kicks, no matter how big or small, for up to 1 hour. We must have 5 movements or 5 hiccups within that hour in order to count it as a positive or reassuring. If we have less than 5, then we go into the second hour, and we must have a total of 10. If it's less than 10 within 2 hours, then we advise the patient to go to labor and delivery or to the office for an NST or a non-stress test. We advise the patients to do this daily at home in the 3rd trimester in order to reassure the patients that the babies are active and healthy. There are a few things that we can do for natural labor augmentation. Oftentimes, exercise can induce labor because the patient's movement can put pressure on the cervix. Intercourse or semen ejaculation can release certain prostaglandins that can also induce labor. Nipple stimulation releases oxytocin that, in a large enough quantity, can start contractions. There are certain acupuncture or acupressure sites that are known to produce contractions as well. There are some studies shown that eating dates in a large enough quantity can produce latent labor, and some sources say raspberry leaf tea and evening primrose oil do the same. Castor oil used to be advised for this as well. However, now it's known that it just causes GI contractions within the colon because of irritation, and this can feel like labor. Most of the time, it just causes GI distress. Braxton Hicks contractions are contractions that do not produce labor. They're usually much more mild than labor contractions, and they can be very normal in the 3rd trimester. They usually get worse with physical activity as well as dehydration. Dehydration produces antidiuretic hormone, which can attach to the same receptors that oxytocin attaches to on the uterus to produce contractions. When patients have polyhydramnios, their fluid levels are high and stretch the uterus at an earlier stage. And term pregnancies stretch the uterus as well, creating Braxton Hicks contractions more often. We can treat with certain things such as oral fluid hydration and rest. The patient can take a warm bath or a shower, or potentially a heat pack in very small increments. Sometimes this can relieve the discomfort. Tylenol is not very effective, but it's the only pain medication recommended in pregnancy. Sometimes support belts can take the pressure off the pelvis, and this occasionally can relieve the contractions. When the patient comes to labor and delivery for a labor check, we first place the patient on the monitor. We assess the fetal cardiac activity, and we want to see how often the patient is contracting. The nurse will oftentimes perform a cervical examination as a baseline. If the patient's not in active labor or a cervical exam greater than 6 centimeters dilated, then most of the time the patient will be rechecked in 1 to 2 hours. If the patient hasn't made cervical change, then the patient's not in labor. If they have a reassuring fetal heart tracing, most of the time the patient is then discharged home so that we can see if the patient will progress on their own at a later date. If we're considering admitting the patient to labor and delivery, several things can affect whether or not we do this. If the patient's gestational age is 39 weeks, 0 days gestation or above, it's more likely that the patient would be admitted with a smaller cervical change. If the patient has a greater parity, it's more risky to let the patient go home because they can kick into active labor much quicker than someone that's never had a baby. If the patient has GBS positive status, it's also more risky to allow these patients to go home, especially if they have a greater cervical dilation, because the patient may not have time, if they kick into active labor, to get their 2 doses of penicillin to protect against GBS sepsis in the neonate. If the patient has made significant cervical change, or if the patient is in active labor, most of the time we would just admit them to labor and delivery so that they can labor in the hospital. If a patient is positive for group B strep or GBS, we treat them in labor. Penicillin is the gold standard for this treatment, but if the patient's allergic, then we may have to choose something else. We oftentimes do clindamycin sensitivities on a GBS specimen, and we specifically do them for patients that have allergies to penicillin. We use clindamycin in patients that are allergic to penicillin when we know that the GBS is sensitive to this. If it's not sensitive, then we would choose vancomycin or Ansef. Ansef is less effective to treat GBS, and vancomycin oftentimes is much more expensive, and it's only dosed every 12 hours. If a patient is GBS unknown, then we only treat in the cases of preterm or if we know that the GBS was positive in the urine. We also treat with maternal fever, maternal or fetal tachycardia, and a history of previous GBS sepsis in a prior delivery. Sometimes we recommend discussing this with neonatology before delivery because neonatology goes by different standards. If the neonatologist prefers that the patient's just treated, oftentimes it's lower risk to do this than to continuously have to test the baby for infection after it's delivered. It's usually joint decision-making between the obstetrician and the neonatologist which direction is the safest to go. Birth positioning within labor can help speed up delivery by allowing the baby to rotate and descend into the pelvis quicker. When we change position, it allows the baby to rotate into a position that allows descent into the pelvis. Oftentimes, nursing staff are trained by a specific course called spinning babies, and this course encourages specific positions that will help this process. When patients are laboring, sometimes they're offered birthing aids, such as birthing balls and peanut balls. Birthing balls can allow for positioning to help with pain as well as rotating the fetus into the birth canal. Peanut balls can spread the legs in a certain position to open the anterior-posterior diameter and allow this rotation and descent into the pelvis, which can speed up the labor process as well as make transition easier. If the patient wishes to bounce on the birthing ball, this can also allow the fetal head to put more pressure on the cervix and to release prostaglandins, which then will allow the patient to dilate faster. And this concludes our module on Labor Management 1.